I'd like to now bring to the stage Dr. Jerry Bartholomew, who's going to tell us a little bit about genotype-guiding dosing of warfarin. Is there a role to perform this?
Thank you. My only disclosure is I have too many slides, Jeff, and that's why I tried to get up before the previous speaker. Oops, I already lost a few seconds. These are my disclosures. So warfarin is the most widely prescribed anticoagulant worldwide still. It's a significant cause of emergency room visits and hospitalization, and anticoagulant-associated morbidity and mortality remain unacceptably high. So determining the appropriate dose of warfarin can take weeks or even months. There are wide variations in dose requirements, partially due to diet, comorbidities, and interactions with other medications. And if you overdose or underdose, you can lead to thrombosis or bleeding or both. And we know genetic factors account for approximately 1/3 of the variation in dose requirement. Just a little review of physiology, warfarin metabolism, and mechanism of action. I don't have time to go into any detail, but the main genes that we're concerned with are CYP2C9, alleles 2 and 3, and there are 18 or more other alleles, VKORC1, and CYP4F2. Now, there are 3 articles in succession in the same edition of New England Journal of Medicine in 2013. This was the clarification of optimal anticoagulation through genetics, or COAG trial, looking at over 1,000 patients, and they had dosing algorithms, including clinical variables and genotype versus clinical variables alone. And the rates of the combined outcome of any INR greater than 4, major bleeding, or thromboembolism did not differ significantly according to dosing strategy. Therefore, genotype dosing did not improve coagulation control, although among blacks, the mean time in the therapeutic range was less in the genotype-guided group, and we'll mention that again later. In the same edition, the genotype-guided dosing of warfarin in the European Pharmacogenetics of Anticoagulant Therapy, or UPACT, over 400 patients with AFib or venous thromboembolism. Warfarin doses were either, again, pharmacogenetic-based or standard dosing. And pharmacogenetic-based dosing was associated with a higher percentage of time in therapeutic range than standard dosing and reduced the incidence of excessive anticoagulation. And the third article, again, this time it was a randomized trial of dosing of acinocumarol or fenprocuman, over 500 patients, again, similar algorithms. The primary outcome was the percentage of time in the therapeutic range of INR. And genotype-guided dosing did not improve the percentage of time in therapeutic INR range, and there was no significant difference observed in the incidence of bleeding or thromboembolic events. More recently, we've had Genetics Information Trial, or GIFT. This was the trial looking at over 1,600 patients who were undergoing hip or knee arthroplasty. Genotype-guided dosing reduced the combined risk of major bleeding, INR greater than 4, venous thromboembolism, or death, and they concluded that genotype-guided dosing may improve the safety of warfarin initiation among patients undergoing hip or knee arthroplasty. So what are some of the potential benefits? It may shorten the time to a stable INR. It may increase the time within therapeutic INR range, reduce under and overdosing, and reduce the risk of bleeding and thromboembolic events. Some risk, it may lead to a false sense of security and inadequate INR monitoring. That doesn't mean you cannot monitor these individuals any less frequently. And then there are risks from the genetic component of only testing CYP C9 alleles 2 and 3 in African Americans, and then they may have a different dosing strategy for them. And there can be errors in genotype or reporting of genotypes, which can have long-term adverse health implications. And who will not benefit? Patients who are on long-term treatment with stable warfarin doses, patients with careful INR monitoring, and then one must consider the cost-effectiveness of this approach as well. This is a very busy slide. It was produced by the Clinical Pharmacogenetics Implantation Consortium. I don't know that you can really read it, but if we're testing for VKORC1 or CYP2C9 with alleles 2 and 3, and you're non-African American, then you may want to use this as a loading dose. And then you also may look at these doses and reduce or increase the dose depending on your patient and their genetic makeup. On the other hand, if they're African American ancestry, you probably don't want to use these unless they do specific alleles that will include that population as well, and you will probably dose them clinically. So in summary, genotype-guided warfarin dosing probably has some clinical utility, but it might be simpler and less expensive to implement wider use of clinical dosing algorithms and closer monitoring of the INR to reduce the harm of anticoagulants. Thank you.